Next talk in the program, and that's updates in the management of TB, HIV, and AI, among everything, in infectious diseases. And I'll invite Dr. Kurian to introduce my colleague, Dr. Rajiv Karthik.
Did you see? No, Rajiv Karthik is the professor of infectious diseases in CMC Velu. But he doesn't need an introduction to this crowd, but I invite him to speak on the topic.
Morning. Can you hear me? Okay. So good morning to all of you. The next 20-30 minutes, we'll deal on some things that I know of and some things that I'm not very sure of, and that is what is new in artificial intelligence in infectious diseases. So it was a learning experience for me as well. So we'll talk about three very important things. We just heard a lot on tuberculosis and the status of TB in India. We'll talk about HIV as well and what are some of the updates. And we'll talk about something that is going to, I think, change the way we practice medicine in the next 5 years. And that is, what is the impact of artificial intelligence going to be? And for us as infectious disease physicians, how can we use it best, to help improve our patient care? So this is from the global WHO TB report that came out in 2024. And these figures really paint a very dismal picture. As Dr. Kurian was saying, we've been doing a lot of things for the last several decades, but nothing seems to have changed. And the number that's really worrying is that last year, the number of new TB cases worldwide was 8.2 million. And this is the highest it has been since 1995. So something we're doing is not right. So maybe we could say that during the pandemic or post-pandemic, the numbers, maybe were not right. But really, the last year's data shows that whatever efforts we're making towards TB control isn't really helping. And we know that there's a disproportionate burden in several low and middle income countries. And as you can see in the slide, India is right up there. We contribute about 25% of cases of TB worldwide. So TB is definitely our problem, and we really need to see what is the best way we can to tackle this. So a couple of years ago, we had the thought, and there was a lot of propaganda to see whether we could end TB by 2025. And these are some of the goals that were listed. To get a 50% reduction in the incidence rate by 2025, we've reached about 8.3%. Number of TB deaths, we wanted a 75% reduction, but about 23%. And the number of people affected by TB and incurring catastrophic costs should be zero. So that's about 50%. So we're almost there. It's the end of 2024. And definitely you can see that we're not really close to achieving these targets. So there's a lot in TB management and diagnosis. There's vaccinations, there's new ways of diagnosing TB. But what I'm going to talk to you about is really about TB therapy and how and what are the strategies that have come up in the recent past to actually enhance treatment of TB and reduce its transmission. So I'll be focusing a little on shortening tuberculosis treatment strategies. And some of you may ask, why do we really need to shorten TB treatment? We know that, for drug-susceptible TB, if we use 4 drugs and we use it well, the cure rates are fairly high. But even then, from the late 80s, we've been searching for strategies by which we can reduce the duration of TB treatment. And of course, we know that compliance is a major issue. All of you have treated patients with TB. Compliance rate can be poor. People have to take medicines continuously for 6 months. So one is to improve adherence. Second is obviously to reduce costs for the health system and people with TB. We talk about DOTS and directly observed therapy, and this to continue it for 6 months is not easy. So if the TB treatment is shorter, people can return to work and thus reducing the household impact of TB. So for many decades, we've actually been stuck with the 6 months therapy or longer. And it's only recently that there have been some changes. So this is a recent study that looked at shortening TB therapy with treatment for 4 months instead of 6 months. Yes, 4 months is still long, but anything shorter is definitely an advantage. So we know that we use 4 drugs for treating TB: isoniazid, rifampicin, pyrazinamide, and ethambutol. And this particular study looked at 2 regimens. In one, they replaced rifampicin with rifapentin, and you may ask why. What is the difference? They're the same group of drugs. Rifapentin has a very long half-life, and so effective therapy and the levels of the drug in the body remain much higher. So they believe that rifapentin has an advantage. So once daily rifapentin was in one of the arms. The second arm, they replaced rifampicin with rifapentin, but they also added moxifloxacin instead of ethambutol. So 4-drug regimen with rifapentin, moxifloxacin, isoniazid, and pyrazinamide was actually used. And the study actually looked at several different statistical analysis, and they used what they called a microbiologically eligible population and an accessible population. And what you can see is that the rifapentin moxifloxacin arm achieved non-inferiority, whereas the rifapentin arm alone, where they just switched rifampicin with rifapentin, didn't achieve this non-inferiority cutoff. If you look at the graph at the bottom, the toxicities, we all know ATT has several toxicities, hepatotoxicity, which is the most significant. The toxicities didn't really change much, and it was the same. So from this, the conclusion was a 4-month regimen of rifapentin, moxifloxacin, isoniazid, and pyrazinamide was as efficacious as a standard 6-month regimen. So a little more information about 4-month duration. Children is a population where adherence, and it's very difficult to complete therapy in children. So this is another population that is looked at, and they looked at the same 4 drugs, but they use it only for 4 months. And this was very, very carefully chosen patients. So definitely this is a trial setup, where the patients were carefully chosen. Children, non-severe disease, who they defined as single lobe involvement, no cavitary disease, no pleural effusion, no upper airway disease. So very, very closely selected patients. But they found in patients, in children who were not really sick or do not have severe disease, again, 4 months was equal to 6 months in terms of efficacy, and the side effect profile also was very similar. So 2 populations in whom we now know that 4 months of therapy may actually work. One is in children, and one is in the general population using rifapentin and moxifloxacin. So obviously, when something works, we get more and more ambitious. So the thought was, okay, 2 months, 4 months, can we cut it short even further? So there was this group called the Truncate TB, and where they wanted to look at with even shorter regimens work. And so this is the trial design that they used. So we had one arm with the standard TB treatments, which continued for 6 months. And in the other arm, they postulated using only an 8-week regimen for TB. So just 2 months of therapy. And they would monitor signs and symptoms. If there was a relapse, this regimen would continue for another month. And at the end of 3 months, if the patient was still symptomatic, not getting better, or smear positive, they would switch them to the standard conventional regimen. So this is what this truncate TB strategy they used, using 8 weeks. I'm not sure if it projects very well, but they tried several different regimens. Right on top is our standard regimen. They use 4 different categories of drugs. And in all of them, if you can see, what they have done is actually given a very high dose of rifampicin. Normally, we would use somewhere around 10 mg per kg. But all these trials actually used doses ranging from 15 to 20 to even 35 milligrams per kg of rifampicin. So these are a little unconventional to us when we think of rifampicin, but there is more and more evidence that higher doses of rifampicin may be needed. and also that it may be reasonably well tolerated. So high-dose rifampicin with linezolid, high-dose rifampicin with clofazimine, rifapentin, levofloxacin, and linezolid in one arm, and bedaquiline and linezolid. So unfortunately, they couldn't take all these arms to completion. So they were able to only do analysis in two of the arms. So the standard control group and the group with linezolid and rifampicin, and the group with linezolid and bedaquiline. And unfortunately, only one of the arms actually showed non-inferiority, and it was a group with bedaquiline and linezolid, along with the standard anti-tuberculosis therapy. So this is still in its infancy, these strategies where we give just 8 weeks and see what happens. But this is the way forwards in terms of where we go with the anti-tuberculosis therapy. So we'll just shift track a little. I don't know how many of you saw a recent update from the Ministry of Health in about September, October this year, where they have approved short duration therapy for multi-drug resistant tuberculosis therapy. And all of you who treat MDR TB would know that it's very painstaking, both for the physician and the patient. So earlier we had to give injectable agents for several months, deal with the toxicities of that. And though in the last few years, the time duration has been shortened to 9 or even 11 months, what we need is actually shorter durations of therapy. And there is some data that even 6 months of therapy would actually work fine. And this has actually been approved by the Ministry of Health, and it should be rolling out quite soon. If not, it already has. So where do we get this information from? And this is a landmark study in my mind, which is a NICS TB study, which looked at just 3 drugs. And the 3 drugs are bedaquiline, protominid, and linezolid. So these are the 3 drugs given for a period of about 6 months. And in this study, it was 26 weeks. And who are the population who this was studied on? One, it was XDR TB, which in itself is a very, very complex and difficult infection to treat. And the second group of people were patients with MDR TB who either couldn't tolerate the conventional regimen or who weren't getting better with the conventional regimen. So really sick people with tuberculosis whose outcomes would have otherwise been quite dismal is whom they studied these patients on. And you can see that at 6 months of therapy, or after 6 months of therapy, the success rates were actually very, very high. 89% in XDR TB attained success, and about 92% in MDR TB. Was there a downside to this? Yes, we know that linezolid is quite a toxic drug. So there was a lot of toxicity, especially peripheral neuropathy and myelosuppression was seen in a lot of these patients. Sometimes drugs had to be discontinued and had to be switched. But this was very, very encouraging, where 3 drugs for MDR TB for 6 months would actually be beneficial. So like I told you, in the last study, one of the concerns was drug toxicity. So this was a study that went one step further and looked at whether we really need a high dose linezolid. In the previous study, it was given at a dose of 600 milligram twice daily. So this study looked at 4 arms. You give linezolid at 1,200 mg, that is 600 BD, or do you give it at 600 milligram OD? Or do we need linezolid for a long time? Can we just give it for something like 9 weeks and be done? So we looked at 4 arms. And what is quite clear is that linezolid 1,200 mg per day and 600 mg actually showed the same results. So to offset some of the side effects, we now don't know that if you just use 600 mg of linezolid per day, you can achieve the same microbiological results and clinical cure, but you're offsetting some of the toxicity of linezolid, which many people don't tolerate over a longer period of time. Finally, what the government of India has rolled out is this BPAL-M regime, which has the same 3 drugs. There is bedaquiline, protaminid, linezolid, but also has moxifloxacin. And you can clearly see in this study that the unfavorable outcomes in this study was significantly less with the BPAL-M regimen, and the adverse effects was also significantly less compared to standard of care. So hopefully going forwards in the next few months, many of our MDR TB patients will not have to go for months and months with 12 months, 18 months of therapy. We can actually have access to these drugs through the government program, and we can actually treat them for 6 months. So that's about shortening TB regimens. So both susceptible TB and MDR TB, shorter regimes are there. And I think we need to use them judiciously to make sure that um, uh, these drugs are available with us for a long period of time. So I just want to shift track a little. I want to talk a little bit about one of the serious forms of TB that we see, and that's TB meningitis. And I want to talk about this experience from our department, where we've used infliximab in severe disabling CNS TB, which doesn't really respond to steroids and anti-tuberculous therapy. So we know that steroids have an effect on death, but do they really affect morbidity and disability? And actually, the study shows that there is significant amount of disability with CNS TB. And this is the landmark study about steroid use in TB meningitis. If you look at the figures on death, yes, death, there is a benefit if you give steroids in tuberculosis meningitis, but significant amount of severe and intermediate disability, even if you use steroids. So these are some of the MRS gradings that we use. And TB meningitis patients, what we were seeing is many of them were left with severe, significant disabilities. And our question was, is there anything we could do to actually reduce the disabilities? These patients were on appropriate anti-tuberculosis therapy. They were on steroids. But in spite of this, or on stopping steroids, these patients actually progressed. So the question was, could we do something for these patients? So this was the question that we wanted to answer. And there had been some initial data on the use of infliximab. You will ask me, that's a TNF alpha blocker. Doesn't it lead to the spreading of tuberculosis? Yes, TNF alpha has a very important role in controlling TB in formation of granulomas, but it's also a potent anti-inflammatory agent. And here we're using it for its anti-inflammatory potential, whereby the CNS inflammation reduces. So this is the population we use them on. Refractory symptomatic tuberculomas, despite adequate anti-tuberculous therapy. Tuberculosis meningitis with worsening on steroid tapering, patients who had visual loss or optochiasmatic TB, and recent onset paraparesis due to an inflammatory arachnoiditis. And the dose that we initially used was 3 doses, up to 3 doses of 10 mg per kg of infliximab. Later on, after our initial series, we realized that we may not need such a high dose. And we have, in the last few patients, we've used 5 mg per kg of infliximab. So this initial was at 10 mg per kg, and it was up to 3 to 4 doses. So some patients responded with 1 or 2 doses, but it was up to 3 doses that we actually gave. So what does this help us to do? One, we could reduce the steroids to minimum. In this way, we could negate the side effects of steroids. We know that long-term steroids have potential side effects. So we could reduce steroids to minimum. ATT was continued after this for a period of at least 6 months, and at least 3 months follow-up on infliximab was done. And we looked for any other flare-up of opportunistic infections that actually could occur. So in about 30 patients that we initially studied, 18 had significant improvement, 7 had marginal improvement, and 4 remained status quo. Nobody actually worsened post-infliximab. And what was one of the markers of actually improvement is that how they responded to the first dose. So if they didn't really get better after the first dose, most of them didn't improve after that. One patient had multidermatomal herpes, and the other had severe COVID-19. And there were 2 deaths, which we feel were unrelated. So this is just a bar graph that shows pre and post infliximab. You can see that the green bar on the left is actually lower grades or MRS1 of disability. And you can see that a large number of patients actually achieved that in the infliximab group. Whereas in the steroids group, the dark maroon and the red columns are very high. So patients, in spite of steroids and ATT, remained significantly disabled in spite of this therapy. So this is just showing that, yes, successful outcomes we saw in about 86%, whereas it was only about 45% in the steroid group. So just an example of the kind of effect that this has. So you can see this initial scan. This was a young chap with left frontotemporal tuberculosis with significant disability. When he came to us, his MRS grade was 3, and we had given him infliximab, and you can see the follow-up scan post infliximab. You can see that most of the lesions have actually regressed, and there is a significant swelling reduction. But most important is the level of disability that actually changes from a grade of 4 or 3. They actually become 1, and they're actually able to function normally. So this may be an effective and safe therapy in a So I'll switch tracks now. I've talked enough of TB, and you've heard a lot about TB. We'll just move on to some recent updates in HIV. And again, what seems to be happening of late is how best can we simplify antiretroviral therapy regimens. And from data over the last 5 years, we know that we have very, very safe antiretroviral therapy, drugs that work very well with very, very low side effects. And we now know that for patients who are virally suppressed, you don't need 3 drugs, 2 drugs are enough. But all the recent information has actually been towards longer acting drugs where patients with poor adherence can actually take them maybe once in 2 months, and then they don't have to take daily pills. So a lot of the recent information and data is on this INSTI, or an integrase inhibitor, which is a long-acting cabotegravir and rilpivirine, not yet rolled out in India, but it has a lot of potential benefits, especially in patients who are poorly adherent, because they don't have to take a pill a day. They just have to come every 2 months, get a shot, and they will be protected for about 2 months. So this is a combination of long-acting cabotegravir and rilpivirine, both of which are given by an intramuscular injection. And this was well studied in a trial setup as a switch in patients who are already well suppressed and have well suppressed HIV. So somebody who is well suppressed HIV on their therapy, if they have adherence issues, it was well studied in these 3 studies. I'm not going to go into them, the ATLAS and the FLAIR study, whereby this therapy was very effective. So everyone will say that these are trial situations. How does it work in the real world? In trials, patients are monitored very, very carefully. Adherence is made sure of. So what I will show you is how does it work in the real world data. So there were some concerns about why this therapy failed. Baseline mutations, resistance mutations, obviously will work against this regimen. Some people with subtypes A1 and A6 and elevated BMI were some of the factors that led to the failure of this regimen. So if you look at in the study or in the trial population, the risk of virological failure for this regimen was 1.2%. So everybody wants to know, would this be the same in a real world cohort, or would it be different? Because in the trial setting, everything is very, very strict and very adhered to, but it may not be like that in the real world. So these are just the same drug used in various large cohorts, and you can see that the failure rate is about 2 to 4%. It's about the same. So what about, using it in a low and middle income country? And that is what this particular study looked at, using the same regimen in Africa. And exactly the same strategy. Patients who are virally suppressed on therapy, you actually randomize them to get this long-acting drug. And this is given as an intramuscular injection every 8 weeks. So really, for a subgroup of patients, such as adolescents, such as people who have barriers to comply with their medicines, this is a very good option, or to actually continue their therapy as they had been getting. And so you can see that with either regimen, either you continue your oral therapy or you take a long-acting intramuscular agent, the virological suppression that was attained is actually the same. So this showed that this novel therapy, where parenteral antiretrovirals are given in a real-world setting, will also work as well as the trial setting. So I'm going to just talk very briefly on two new agents that are being developed and have been actually approved for use. One is a drug called lenacapavir. It's a long-acting capsid inhibitor. And the advantage with this drug is that you could use it subcutaneously every 6 months. So this is one step further than the every 2 months. It is also available as an oral pill. It can be taken once a week as an oral tablet, or it can be taken as a tablet once a day. So these are different formulations that can be used. And what seems to be promising is the fact that if it can be used once in 6 months, it really is something that people could look forward to. You need only a shot twice a year, and your HIV can be suppressed. Another drug is islatravir. Again, it's a long-acting nucleoside reverse transcriptase inhibitor. Currently, it's being tried in a fixed dose combination with dorivarine or as a standalone agent. There were some issues with the higher dose, which was associated with lymphopenia. And so that particular preparation of a monthly oral formulation is no longer being tried out. So this is another regimen where you have, previously I talked about long-acting injectable agent. So then some people may not be happy with taking injections. So can we do weekly oral medication? So you just take a pill once a week and you're protected. So different ways in which to improve overall adherence with ART. And this is a regimen that uses the two drugs that I mentioned, islatravir and lenacapavir, as an oral weekly regimen. And again, this has all been studied in patients who are already virally suppressed or who have, good control of the HIV. But for adherence issues, we might want to change. So this study looked at a weekly oral therapy with these two drugs versus continuing their same standard daily pill. And the viral suppression at about 48 weeks is actually identical. So these are strategies which might work going forwards. You take a pill once a week, take an IM injection once in 2 months. So that is where we are moving forwards in terms of HIV therapy. There was a lot of interest in neutralizing antibodies that came out a couple of years ago, but unfortunately, this hasn't really taken off. And there are a lot of prerequisites. We need to make sure this is a very susceptible virus. We have to make sure that the levels it achieves in the blood are very good. But in spite of all these, it is not even as good as a conventional ART. So this is really still far away from prime time or from regular use. But this is also there. But it definitely needs much more work because before it can come out as an effective agent. So two things, we see a lot of opportunistic infections with HIV, and I just want to touch on two factors. One is the study that looked at, I told you about steroids and TB meningitis. So this particular study looked at adjunctive dexamethasone for TB meningitis in HIV positive patients. So we had this information about steroids in TB meningitis, but this is steroids in TB meningitis in HIV positive patients. It was done in Vietnam and Indonesia. And though we all use steroids in TB meningitis, whether HIV or not, this study actually clearly showed that the rates of success or the death from any cause is actually fairly identical in patients who got steroids or who did not get steroids. So we might have to rethink. I mean, this is one study. I agree that we need more information. But in this particular study, in patients with fairly advanced HIV who had TB meningitis, additionally giving them IV dexamethasone followed by oral dexamethasone had no outcome on mortality. So that's just something to chew on. This is a little different from what we usually practice. The other opportunistic infection that we do see now and then is disseminated histoplasmosis. We do see a handful of cases every year. And it's cumbersome to treat these endemic mycosis sometimes because amphotericin has to be given for 2 weeks, problems with that, hospitalizations, hospital-acquired infections. So all these are issues. So this actually trial looked at, can we just give a single dose of liposomal amphotericin and in patients with HIV and disseminated histoplasmosis. So when we say single high dose, it's a dose of 10 milligram per kg of liposomal amphotericin, just as a single dose. So this looked at 3 strategies: single dose liposomal amphotericin, conventional therapy where you give it for 2 weeks and then follow up with itraconazole, and another strategy where you give 10 mg per kg on day 1 and 5 mg on day 3. And what it actually showed with a much lower toxicity rate is that a single dose of 10 mg per kg of liposomal amphotericin actually works very well in these patients with disseminated histoplasmosis. You will save a lot of time, hospitalization, and other costs if you could use a single dose of liposomal amphotericin and follow it up with itraconazole. So that's just about HIV and a few of the opportunistic infections and the changes in management that we see. So I know I'm running out of time, so I have to talk about this as well. What is the role of artificial intelligence in infectious diseases? So we know that broadly, if you look at AI in medicine, and we know that AI is slowly coming into all fields, there are two main ways of looking at it. One is the physical and one is virtual. So by physical, I mean all the devices we wear, our smartwatches, our iPhones, that actually collect health data from us. So that's what we mean by physical. These are actually machines that either collect data or we use these machines to do things. Virtual is where all the interest lies. And there are 2 main things that we need to understand. One is machine learning and what we call deep learning or reinforced learning. These are 2 of the ways that this would actually work. So these are things in which AI can actually help, not in ID specifically, but any field of medicine. Early detection of disease, can it help in decision making, treatment plans, and can it improve research? So when you look at the field of infectious diseases, what are the ways in which artificial intelligence can be used? One is diagnostics, and we know that a large number of information is there about diagnosis, especially using radiographs and chest radiographs, and all forms of radiology have actually shown us that AI can be used in, especially in resource-limited settings, for things like reading chest X-rays and picking up, abnormalities. So that is one. Surveillance, it's useful in outbreak detection and control, personalized case management, developing antimicrobial agents, and clinical decision and support forming. So I'll just show you just 2 examples of how AI can be used. And we know that diagnostic radiology has now moved into the path of AIs. And for any sort of image, whether it is a chest X-ray, whether it is a CT brain, whether it's a chest CT, for all of these, you have AI-generated algorithms. And especially in settings where there's a paucity of radiologists and we're not able to read X-rays, large volume of X-rays to be screened. And for diseases like tuberculosis, this has really revolutionized the way the chest X-ray can actually pick up abnormalities, and it can alert the clinician about these abnormalities. So this is one way, especially in low and middle income countries, in certain situations like prisons, refugee camps, where a lot of X-rays are done, but there's nobody to go through the whole set of X-rays. This can actually filter out the normal X-rays. So diagnostic radiology to pick up infections is one of them. This is another example of a mobile app to actually measure antibiotic susceptibility. So you have a disc diffusion plate there. All you need is a phone, takes a picture of that, and it has a built-in algorithm to, to interpret what is the disk diffusion that it's actually capturing, and it will give you an antibiotic susceptibility report. I'm not sure that I would be acceptable to this, but definitely this is the way forwards, and this is how we can use AI, especially in remote settings. You can get an antibiotic susceptibility report also like this. So another example of how artificial intelligence can actually help us going forwards. There's several other examples to even for outbreak investigations and disease surveillance. I'm not really going to go into that for lack of time. So with that, I will stop. Thank you very much for your patient listening. And if there are questions now or later, I can take.
Rajiv, I thank you for a very nice presentation. Just regarding the short course, one of the major difficulties in evaluating short course therapy was the choice of the clinical outcome and the choice of the group of people, subgroup issues. Now, if you want to know whether something is effective in short course, you really want to know what is the relapse rate at 2 years. And how many of these short course evaluations have looked at that very effectively. And the other thing is, you said subgroup with some special issues can be taken out. But in general population itself, diabetes, uncontrolled diabetes in India is a huge group which may not behave as the same. So you cannot pool them and do a short course, look at cure rate at 4 months and 6 months and say effectivity. So in your evaluation of your studies, how many of these things have actually looked at 2-year relapse rate and leaving out the subgroup of diabetes?
So definitely excellent question. And we know that these studies very carefully pick their patients. So 2-year relapse rates have not been looked at. It's quite short follow-up, at least 12 months is what I saw at max. Secondly, I didn't particularly come across uncontrolled diabetes being particularly included or excluded, at least in the 4-month trial. I'll have to look and see whether those were included or excluded, but there were a lot of exclusion criteria. I'm not sure whether diabetes was one of them. And yes, not sure in the real world setup, especially in a low and middle income country like ours, whether it would work. But just that there is evidence slowly that maybe at least in some people 4 months would work. Definitely needs to be studied longer in critical populations like diabetes and things like that, whether it would actually work in them or not.
So I think we're running short of time. So thank you very much, Rajiv, for that excellent presentation on updates in HIV, AI, and TB. There are many questions for